Selamat pagi Bapak Ibu semua. I think we should start now before time flies. Good morning, distinguished ladies and gentlemen. Welcome to SMERU. I'm Yumna. I'm a researcher at the SMERU Research Institute. First of all, I would like to thank you, all of you, for coming to SMERU at the very first FKP hosted by SMERU this year on May, usually on May, exactly at the May Day. I'm sure that all of you today wake up earlier than maybe yesterday in order to get here on time. And for your information, we will have five seminars of Forum Kajian Pembangunan this month hosted by SMERU with very interesting speakers from different background research, both from internal SMERU and also we have some guest speakers from all over the world actually. Like today, it is our honor to have Mr. Michael Trisolini from the Research Triangle Institute International based in North Carolina, I think, who will elaborate his comprehensive expertise on quality measurement and quality assurance for health insurance programs. I think this is very relevant to our country today as we will implement the universal health coverage starting in 2014, next year, 8 months from now. But before delivering his presentation, let me briefly introduce our distinguished speaker. I found this at the IDR's website, your resume, your resume. So it must be correct, right? Okay. Mr. Michael G. Trisolini, PhD, is the Director of the Healthcare Quality and Outcomes Programs at RTI International. For your information, the health section in RTI is one of the largest sections at the RTI, and Mr. Trisolini has more than 27 years of experience in health services research and management. So, from in particular in healthcare quality and outcome, he has also very broad research experience from public reporting quality and then paper performance and evaluation of quality and care and outcomes and so on, that he will elaborate more today here. And he holds an MBA from Harvard University and PhD in health policy from Brandeis University. Is it in US or? Okay. So for now, I would like to allow Mr. Trisolini to start the presentation. Time allocation, is it 45 minutes to 1 hour for the presentation?
Yes.
You know? Okay. So we have 45 until 1 hour for presentation, and then after that, rest of the time we can allocate for the discussion. Okay, thank you.
Well, thank you very much. Really appreciate the opportunity to speak here today at SMERU. I've been reading about the wide range of research that you conduct here on many issues related to poverty reduction, including health. And it's also a very exciting time to be here in Indonesia with the development of your new national health insurance system through BPJS with the goal of universal coverage. So it's a great goal, and we're really moving ahead on a goal that's one that many countries are trying to achieve as well. I want to give you a bit of background on RTI, for those of you who may not be familiar with RTI. So our full name is Research Triangle Institute. We are a non-profit organization that was formed by the universities in North Carolina. Triangle refers to the area of 3 universities. It's Duke University, University of North Carolina, and North Carolina State that form a triangle down in the state of North Carolina. So we were formed there 50 years ago, so it's been many years, and now RTI has branched out and has offices in many different parts of the United States and around the world. So we have an office in Boston, where I work, and offices in Washington, D.C., Chicago, San Francisco, Ann Arbor, other cities in the United States. Also, many offices around the world, including an office here in Jakarta. We've been here for over 20 years now, mainly working in the areas of education and local governance. And so we are now beginning more work in healthcare as well here. So RTI has long experience here in Indonesia, although in some other sectors. RTI is a fairly large organization, probably the largest research and development organization in the United States, with about 3,000 staff and many different divisions. Healthcare is the largest division of RTI, although we also do a lot of work in education, local governance, also in environmental issues, as well as another area of focus for RTI. Our funding mostly comes from government agencies. The U.S. federal government funds a lot of our work. We also receive a lot of funding from foundations, such as the Gates Foundation, the Robert Wood Johnson Foundation, and others working in healthcare. Myself, so I am director of the Healthcare Quality and Outcomes Program at RTI, part of a division that works on health services research generally. I also work with many colleagues working on healthcare financing and payment issues, aging and long-term care, and women and children's health as well. So one of our goals is to try and develop multidisciplinary teams that can work, say, across financing and quality has been one of our themes, to try and bring together the health financing and health quality perspectives together into the same program. So that's one of the things I'll be focusing on today, especially in the context of your effort to develop your national health insurance system here in Indonesia. For the past 12 years, I've been working on this topic with the U.S. Medicare system. So the U.S. Medicare system, as you may know, is a national health insurance program in the United States, but only for elderly people, age 65 and older. So the United States has not yet quite achieved universal health coverage, as you may know. Mr. Obama, our friend Mr. Obama, is working on that, trying to achieve it. Being from the state of Massachusetts is very interesting because we are the first state to have universal health coverage, or almost anyway. And that was developed by our friend Mr. Romney. So Mr. Romney was the governor of the state of Massachusetts and helped to bring in universal health coverage. And then that idea, I think Mr. Obama took the idea and tried to develop it nationally. And so we said to Mr. Romney, we liked him as a governor of Massachusetts, but we said, we don't think you're ready to be president. So we said we prefer Mr. Obama. So we thank him for that, though. And so what I've been doing is working on, with the U.S. Medicare system, on trying to bring together the perspectives of finance and quality. So I have my friend who's the director of our health financing and payment program, and we work together on joint projects with trying to think about how to bring quality assessment, quality measurement, quality assurance into health insurance programs so that we can look at the cost of healthcare and the quality at the same time and link the payment system to the quality as well. And we've been developing many different programs in the U.S. That have been sort of pilot programs, and now with the new Accountable Care Act and the development of new initiatives for accountable care organizations and pay for performance and quality measurement are now being integrated into the main body of the U.S. Medicare system. I should also tell you I have a history in Indonesia. I worked here 25 years ago, back in 1988 and 89, many years ago, with the Department Kesehatan at Pusdiknakas over on Jalan Hang Jebat 3. Kebayoran Baru. And I worked there. I was actually at the time at Boston University in the School of Public Health, and we had a joint project working on development of schools and academies for public health workers around Indonesia. So I had the chance back then, 25 years ago. I didn't have quite so many gray hairs back then, but we worked in many different cities around Indonesia, so I had a chance to learn about worked here for about 8 months back then. So visited Semarang, Surabaya, Bandung. It was called Ujung Pandang back then. I know it's now Makassar. I have to say that saya tahu bahasa Indonesia sedikit saja. So today I have to speak bahasa English. But I'll move ahead with the presentation, and be happy to take questions of clarification during the middle. It's a long presentation for 45 minutes to an hour. But if we want to have discussion, certainly have that at the end as well. Okay, so the presentation outline today, I'm going to talk about some basic introduction about the quality and finance perspectives, then talk about quality measurement options in healthcare that we've been working on at RTI for many years, and then quality assurance methods also, so thinking about them somewhat separately. So we want to measure quality first and figure out how to make sure we have good measurement, and then think about assuring quality and maybe improving quality as well. And then because of the context here with your national health insurance system being developed, I'm going to talk particularly about how healthcare quality measurement can be integrated into health insurance claims data. That's been one of the movements we've been working on with the U.S. Medicare system, and it's something that I think Indonesia may want to consider for the future as you develop BPJS. It's something that may take a number of years to accomplish, but thinking in terms of the long-term goals, where do you want to get to with BPJS in terms of quality measurement and quality assurance? And talk about the different types of health insurance claims data that are possible, so you can think about how to maybe integrate the data collection for quality into the health insurance claims system as it's developed for BPJS. Okay, so as we're saying, it's great to be here at the time when you are developing your universal health insurance coverage. We started on January 1st, right, 2014. It's a big job to get ready for it, but I know it's also exciting to have that ambitious goal to move toward. So the perspective I'll take today is on this slide. Is that expanding access to healthcare is a very important goal, and I realize that achieving universal coverage is an important goal for the country. But a parallel goal, and the one we've been working on at RTI, is how to link access also to good quality of care. So, of course, it's very important if you have access to healthcare services that they also be of good quality, so that they help the patient improve health and improve health outcomes for the entire country, and help the country achieve its healthcare status objectives, and assist economic development. And I know you all are focused on poverty reduction, and of course we believe that good health is an essential part of helping people get opportunities to move out of poverty. Okay, so another by way of introduction again, thinking about the range of goals in health policy. What are we trying to achieve? And that's one of the reasons health policy, I think, is complex and challenging, because we have a number of different goals to achieve all at once. So it's, again, a big job to try and achieve all these. So expanding access to achieve universal health coverage, I think, is a very important one. And then the next one would be sufficient payment to hospitals, doctors, and other providers. So I know there's a lot of work going on right now with planning for BPJS, and working with your history and ASPES and GEMPESMOS and other programs to make sure that the payment system, so that you have the system using case-based groups here in Indonesia, or CBGs, similar to the DRG system that we use in the US and other countries. So we need to make sure that that system is in place and ready to go on January 1st, so that when January 1st happens, the hospitals will continue to be paid, right? So they can pay their staff and keep everybody moving ahead. I know it's a challenge, but it's a good goal to have. Next is cost containment to ensure affordability of healthcare for the government and for the citizens. So we need to make sure that the costs of healthcare, so we're doing payment to the hospitals, but we need to make sure we're paying for healthcare that's of good quality and value, so that sometimes, people sometimes go to the hospital. You've probably seen when they really don't need to go. Like in the emergency room, it gets very crowded with people who aren't really too sick. It'd be good if they were treated at the puskesmas instead, and not at the health center, or maybe even just take a rest at home. Right? And sometimes, for example, drugs like antibiotics are given to patients with cold or flu, and if it's a virus, we know that antibiotics don't help. But sometimes the doctors want to give the patient something, right? It's almost marketing, right? So the patient wants something. I'm here. I need to get something from the doctor. And so if the doctor just says, "Go home, take a rest," ooh, patient not happy, right? They want the drugs, but that costs money, and it's a cost to the government, and not a good way of spending the government's money or the citizens' money if they're paying for the doctor. And then assuring quality of care provided and improving quality over time, then is the next goal. So I think one of our big challenges in healthcare is to achieve all these at once. Now I'm going to focus today mainly on the quality of care goal because we have limited time. It would take us longer to go through everything at once, but I'll be relating the quality back to these other goals because I think it is important to think about all these goals at the same time because we want to achieve them all. Okay, so next topic is quality measurement. How do we measure quality? We think of quality, our usual framework for this is three different types. We call structure or input measures, process measures, and outcome measures. And this is the way that healthcare quality measurement is usually broken down. We think of the first topic, structure or input measures. Now this is thinking like an economist. I have some good friends who are economists. I'm not one myself, but I do like to say some of my best friends are economists. They talk about healthcare as a production process. So how can we think about what are the inputs into that healthcare production process? What do we need? So inputs are what are the first piece of it. We need to make sure we have the right inputs. So one of them is qualified physicians, nurses, and management staff. We may have doctors in a hospital, but are they the right kind of doctors? If it's a heart hospital, we may need cardiologists, not family practice doctors. And we may need surgeons, not just physicians for internal medicine. And are they qualified? Do they have good training? That's always a big question, right? How to make sure that the doctors have good training, and how can we be assured of that? Next is licensed or accredited hospital facilities. And this is an issue that's across many countries. How do we check on the quality of the hospitals? What's the accreditation or licensing process? Is it a process that's very detailed and careful, or is it a process that's a little too fast and not too detailed? It ranges quite widely, as you've probably experienced. And then well-maintained medical equipment, information technology, sufficient stocks of pharmaceuticals and medical supplies. So this is the inputs perspective. So this is one of the basic measures of quality. Next is process measures. So this is the procedures used to diagnose a patient, prescribe testing or treatment, and ensure that the testing and treatment is carried out based on clinical guidelines. For example, if we have someone with hypertension, I know that's an issue here in Indonesia, where diabetes is a growing problem, right? How often should they be tested? We have a guideline in the United States where we say the testing of diabetics for blood sugar, or glycosylated hemoglobin, as the doctors would say, should be once per year. But some people argue, oh no, that's not enough. We need once every 6 months. So these are the debates we have about setting up what are the rules. And then once we have a rule, then we can measure, for each diabetic patient in our hospital, how many of them had the test every year. And then we can evaluate, and that's a way to measure quality. What percentage of the patients had the test once per year, as the clinical guideline indicates? Similar with blood pressure. How often are we checking blood pressure? And what's the level we think is too high? Is it 160 over 90? Is it higher than that where we want to be concerned? When do we start treating hypertensive patients with drugs? And when do we treat hypertensive patients with diet and exercise? Of course, they would prefer drugs, right? It's much easier just to take a drug than to eat right and exercise. So I have a challenge with exercise myself, so I know how hard it is. So again, that's the kind of clinical guideline we think about. What is it? Do we wait until the patient has blood pressure of 160 over 90 before we prescribe drugs? And as you can see, this links back to cost. Because of course the cost is much less if the patient is treating with diet and exercise, right? Cost to the healthcare insurance is zero. But then when we start giving drugs, the cost goes up. So we're trying to link the quality measurement to the cost as well. Now, and then in process measures of quality, we think about different types of problems. And we can have several different ones. You can see here underuse, misuse, and overuse can all be problems. We usually think of underuse as a problem, where the patient is not able, say, to get to a hospital. They live in a rural province. And that's related to access. So you can see that we may have access in the sense of being covered by BPJS, but is the patient able to get to a hospital for treatment, say if they need a surgery, like if their appendix is infected? And then similarly, are the patients being treated quickly enough with drugs when they do need the drugs? So if the patient has bacterial pneumonia, so bacterial infection, do they get the right antibiotics? And then it relates to the next one, misuse. Do we have the right drug for the disease the patient has? So again, the example of antibiotics being prescribed too often around, and this happens around the world, for people with cough and cold, because it's usually a virus and it's a misuse of drugs. And then sometimes overuse. So this might be the situation where we have the crowded emergency department in the hospital with many people who don't really need that level of treatment. And that makes it actually hard for the people who do need the treatment. So it's a double problem in crowding up the emergency room. So again, more ways, and then we can translate all of those clinical guidelines into measurement. So that's the challenge for us in healthcare quality measurement. How do we take those guidelines that are developed by doctors and other medical professionals and move them into measurement so we can actually have a way of measuring quality in healthcare? And then finally, outcome measures. So this is the final goal. We reduce morbidity and mortality and improve quality of life and patient satisfaction. So the challenge with outcomes is they're harder to measure. They may take a while to measure. So usually our measurement is on inputs and process. So is the patient able to, with cancer, can they access a cancer doctor, an oncologist or not? Are they receiving the right chemotherapy drugs? Because the outcome, the continuing to live or die may take many years, right? So the patient may live with cancer for many years, so it's harder to measure because you have to wait so many years. So we often focus the measurement of quality on the inputs and process measures. On the outcomes when we can. For example, here we're talking about patient safety. If the patient is given a drug that they have an allergy to, that can cause big problems, right? So this is an outcome measure that's really quick and easier to measure. So we can check to see how frequently patients have allergic reactions to drugs, and how can we develop a system to prevent that, to check for the allergies. Okay, then given that we have some measures developed, then we next need to think about data sources. There are many different types of data sources possible. So this is another issue to consider here in Indonesia. What types of data sources make the most sense here, given the data you have available and the cost of developing quality the data measurement systems. So you can have basic records on licensing and accreditation. That's a low-cost method. So it's an input method. So we can have some basic information on the doctors and nurses. We can also do, say, household surveys are sometimes done for immunization of children. So you can take a sample. I know surveys can be expensive to do, but you can maybe take a sample. Patient registries, again, for immunizations or specific diseases like hypertension or diabetes or strokes, to track the quality of care for those high impact diseases. So the patient registries are usually selected. What's the most important diseases for Indonesia? What are the major causes of death? I think I saw that the leading cause of death now is stroke in Indonesia. So that's a very important disease, and maybe hypertension is many of the people in the population, it's about 31–32% of people in Indonesia have high blood pressure. So it's a big concern also. So. Then medical records are kept in the hospitals and clinics, and so those can be either on paper or in the computer. If they're in the computer, it's easier to use the data, but it's difficult to get the computerized medical record systems going, so that's expensive. Then the laboratory and pharmacy data systems to check on whether the patients are getting their blood sugar tests for the diabetics and the right drugs. And then finally, the health insurance claims data. That's the one I'm going to focus on today, because I think that can be one that's can give you a good balance between detailed data and relatively low cost of data collection. That's our challenge here, to think about that balance of what is the useful information for quality measurement and quality assurance, but where the cost of data collection is not too high, to find the right balance. So this is something I'm going to suggest might be worth studying for Indonesia as well, given that you have the new health insurance system being developed. Okay, then the next, once we have the data collected, we want to think about targets and what are the goals for Indonesia. So I'm going to give some basic options here. So fixed thresholds, for example, if we have a goal of testing the diabetics once per year, we may say, is it possible to get 100% on that one of all the patients? Hard to do, right? And some of the patients, you tell them to take a test, what do? They just go home, right? Some of the patients, because the test requires taking blood, but some patients don't like the needles, right? Stuck in their arms. I don't like it myself. I still do it because I'm in healthcare. I have to do it, right? Or else I would be, my family would tease me. So we set a goal, a fixed threshold of 80%. We said, your goal as a hospital or as a clinic is for your diabetics, we want 80% of them tested once per year. If you do that, we will call you a high quality clinic. If you don't do that, we will call you a low quality clinic. And that gives them a specific target to shoot for. So that our specific goal, and that way they can determine if they're able to achieve good quality. And we can also talk about improvement over time. We can say, you can start with 80%, but next year we want you to do 82%. And 84, we don't want you to make it too easy on you, right? We don't want you to be able to rest. You have to keep working hard. So those are the kind of goals. And then other types of goals, we can also compare to other hospitals. And we can say which hospital is better and which hospital is worse. So no one wants to be at the bottom of the list, right? So the comparisons can be powerful. And sometimes we have to adjust them by the types of patients. We call it risk adjustment. So for example, if you're in a rural area, or patients have a hard time getting to the hospital, you may want to set a lower goal because it's harder to achieve the goal. Okay, so that's some basic topics on quality measurements, some of the options that you may want to consider here in Indonesia, and that have been tried in other countries around the world. The next is quality assurance methods. So once we've collected data on quality, how do we then assure the quality over time or arrange for quality improvement? So the first and most basic option is what we call licensing and accreditation. So the hospitals need to be licensed by the government, right, as acceptable hospitals, especially when you have government health insurance. How do we know that this hospital should get money from BPJS or ASKAS or Jamkasmas? The government has to certify the hospital as one that's good, a good hospital for receiving payment. And this can include a number of different criteria based on the number of doctors, number of nurses, qualifications, types of equipment. Can include also some process measures. Are they following up with the diabetic patients, they say with the surgical patients? But one of the challenges here, if we look down here at the challenges here is that often, thank you very much. I have a pointer. Yeah, is that this often focuses just on the outliers, as we call it, or we call them the bad apples. So we look for the bad hospitals or the bad doctors. And that is helpful because it is important. There are some that are not doing a good job. But the concern has been that does this really improve quality overall? Just focusing on the outliers. So there's been some movement, as I'll talk about in a minute, to try and balance that with other types of quality improvement perspectives. The other challenge with licensing and accreditation is the detail and the rigor and the follow-up. Sometimes, this happens in the U.S. and many countries worked in, that you can identify problems, but then do you follow up? Do you insist on improvement? How quickly does the follow-up have to happen? And having health insurance actually is helpful in that because you have a lot of influence over the hospital to require improvements because you can say, well, we're not going to pay you anymore. Is BPJS going to keep paying you if you have problems? And that's a way to follow up. So, or you might give lower payments to hospitals that have problems in accreditation or licensing. So the nice thing about health insurance is that it makes the hospital pay more attention to the government. Right? So that because they're getting a lot of payment from them, they need to pay attention to the government's requirements and quality goals and quality assurance methods. Another method is medical record audits. So this is where you would take a sample of medical records, and sometimes what happens is a team of nurses will go into a hospital and pull paper medical records. Some of you may have worked in medical care. I've seen the rooms full of the paper medical records, and you can just pull out some at random, then open them up, and see what happened to the patient. Was the patient in for a virus and did they get antibiotics? Not good. Was the patient in for coronary artery disease and did they get the right drugs that they were supposed to be getting? If it's a patient at risk for stroke, did they get, say, warfarin if they have atrial fibrillation to prevent blood clots that can cause strokes? And this is also based on clinical guidelines, process measures. But again, one of the concerns here is this is focused mainly on finding problems for the bad apples, we said. Who are the doctors? Maybe one department is a problem, one doctor is a problem, or one hospital is a problem. And again, the concern is how much do we follow up? If we find problems, what's the next step? And one of the issues with medical record audits is they tend to be focused very broadly and sometimes not enough detail in one particular area, such as diabetes or stroke So that if the medical record audits are really focused on stroke patients only, maybe for this month, then you can have a more detailed understanding rather than looking more broadly at the hospital's patients as a whole, as sometimes a criticism of this method. Okay, the newer efforts are called continuous quality improvement and total quality management. And these actually came from business and industry originally. The famous businesses that use these most effectively are the Japanese car companies. So they're very famous for using these methods, and we know that in the 1970s and 1980s they used these methods to out-compete the American car companies. Right? So to this day I can tell you, my wife and I, we're shopping for a car, we only shop for Honda or Toyota. We don't look at Ford or GM. No. So I have a, actually I should say, I have a Honda, my wife has a Nissan, so it's still Japanese. So they were very effective with these methods of improving, and what happened was they found that the secret was that improving quality can also reduce costs. Right? So, for example, if you have diabetics, if the rate of diabetes goes up in Indonesia, you have to be worried about the long-term effects of diabetes on the cost of healthcare. Because what happens with diabetes? Eventually, if it's not well controlled, if you have low quality of care, then you get very high cost complications. You know, the neuropathy, where often patients have to have their legs amputated, you know, and that's very expensive, and then the patient is disabled. If we can prevent that cost, it's cost of the surgery, cost of the hospital days from the amputation, help people stay more productive in their work lives. Also, in diabetes, you have kidney disease, right? So diabetes can cause kidney failure. And with kidney failure, then that's very expensive. If they go for kidney dialysis, oh, terribly expensive. And then also you can have eye disease, right? Retinopathy and heart disease. So by providing good quality diabetes care, you can prevent those costs. And so that gives BPJS a big incentive to say, we are going to look at quality of diabetes care because we want to make sure that 10 years from now, we don't have a lot of patients with amputations and needing kidney dialysis. So again, thinking about how the health insurance organization needs to integrate quality of care now to help plan for the future. So what the focus was here, again, one of the innovations here in continuous quality improvements is to say, we're not only going to look for bad apples. You know, it's always nice to be able to say, this person is doing badly, right? So we find them and we punish them, right? It's always good to punish people. But instead, we're going to say, we're going to look at the average performance, not just the outliers. So if you think of quality performance as like a normal curve, the bad apples, you're chopping off the tails of the curve. But here with continuous quality improvement, you're shifting the mean, you're shifting the central, and so the whole distribution shifts upward to better quality. And so you have a bigger impact overall, because you're not just chopping off the tail, you're shifting the whole distribution to improve quality. It's a much bigger impact. That's the theory that's implemented well. Another challenge here is there's a focus on multidisciplinary care teams. In the factories, they had quality circles, and they allowed the average employee to have more say in how the factory was operated for the Japanese car companies. And in the United States, there's a big debate about what's the role of individual doctors, and other countries too. Because the doctors will always say, we are responsible for the patients, right? And in fact, one of the best clinics that's doing continuous quality improvement is called the Marshfield Clinic in Wisconsin. We were working with them. And the doctor there, who's the medical director, said, it's a big problem for me because the doctors don't want to work with other people. They don't want to work with nurses. They don't want to work with diabetes educators. They don't want to work with public health people because they're the doctors, right? they should be the captain of the ship. And he said that when he was trained, he himself, he was leading this effort in continuous quality improvement. He said, when I was trained as a doctor back in the 1970s, I was told that I should never trust anyone. You know, that your patient is your responsibility and don't trust anyone to help you. And he said, you know, that's the way a lot of doctors are trained. And it's a big problem if you're trying to build teams, because the doctors aren't good team players. So, I mean, the doctors will argue, well, we're responsible. And so this is the debate going on now. What's the right balance between teamwork and responsibility for the doctors? But a number of healthcare organizations are testing this. Yeah.
Mike, I just have a quick question. So the second bullet up there on continuously improving average quality versus minimum standards and identifying outliers, that's a big cultural shift in how we assess, right? It's good to talk about it, but actually making the cultural shift organizationally within the healthcare system itself, moving from an environment where minimum standards have been the norm to something like this. It is a big shift.
Absolutely.
Can you talk a little bit about in your experience, some of those organizations or systems that have made that shift and what the challenges in that shift were?
Sure. Yeah, making that shift has been challenging for many organizations in the U.S. and in other countries. I think one of the ways that it's sometimes accomplished more easily is if you're starting with, say, new hospitals or new clinics where there's not an entrenched culture. That's one method. Another is you need a leader. You need strong leadership who believe in this method. And leaders who are willing to take many years to make the cultural change happen. So yeah, it's true that these things are not quick to achieve. As I was saying, the doctors have a mindset that's not team-oriented. But they are methods that can be beneficial if they can be implemented effectively. So you may want to start, say, with basic licensing and accreditation, and develop ways of moving toward some of the more modern or more newer methods that are attempting to look at quality improvement for the average performance rather than the outliers. But it certainly is challenging. A lot of it depends on leadership in the organization and how much, and also selecting the right staff. As some of you may have experienced, when we look at computers in healthcare, can you guess whether the older doctors or the younger doctors are the ones who are more likely to use computers? The younger ones, yeah, because I mean they grew up going like this, right? And the older doctors, many of them didn't grow up with computers, and that's a big problem all over the world. And it's an amazing cultural shift, actually. That's been striking to see all over the world, that there's this new generation of doctors and nurses who grew up with computers and are much more comfortable working with them. And so one of the big questions is, how quickly do we move toward electronic medical records in hospitals and clinics? We were talking about this at the PICI conference in Semarang last week on health IT, that there are some experiments going on in some private hospitals here in Indonesia with electronic medical records. There's some experiments going on in Thailand. One of the Thai representatives was talking about that. And there are experiments in the United States. I've been working with clinics on implementing medical records in the United States, and it's really heavily dependent there also on the leadership. If you have a leader who is very oriented toward electronic medical records, then it can happen, but they have to also hire the right staff, the younger staff, who will support that vision. So if you have a vision and you hire older doctors who are going to be more respected, but they're more resistant, it can be a big problem. So these are things to consider and to think about, sometimes for the long term, sometimes for the short term. But I think one of the other positives about Indonesia is that you have such a diverse country and large country that innovations in healthcare quality management can be developed in certain areas, say maybe in say Jakarta or Jogja, other big cities first, and then spread to other areas as well. Okay, some other focus on continuous quality improvement. Again, as I mentioned, we're trying not to focus so much on the bad apples. One of the cultural issues about bad apples is that a lot of the leaders of continuous quality improvement will stress is that when you are looking at outliers, people see that pretty quickly, right? They see that, oh, the boss is looking for the outliers. The boss is looking for the bad apples. So what do? They put their energy into not being a bad apple. And is that always best for the organization? Well, no. So the idea is to try and shift the culture to where people are focusing on the needs of the organization and not on avoiding looking like a bad apple. So that's another lesson that originally from the Japanese car companies that is now being applied in healthcare in a number of different countries. Another goal here is to look at external benchmarks. So the shift, again, from the minimum standards to another different perspective. Instead of looking at minimum standards for quality, what are the leaders in quality and how can we match them? How can we learn about them? So people from different clinics will go visit the best performing clinics. And one of the nice things about healthcare is that people don't compete across geographic distances, right? So that hospitals in one city do not compete directly with hospitals in another city, unlike car companies. So you can have a visitor from another hospital, it's not a direct competitor, and you can learn from each other and learn methods that may be applicable to your hospital without having to worry about later on competing with that hospital. So you can have what we call learning collaboratives in healthcare much more easily than you can in manufacturing companies like cars, where there's competition all over the country. And so part of this is also thinking about learning from other hospitals and clinics about quality improvement and sharing the lessons learned. Okay, another method for quality assurance is confidential reporting of quality measure results. So this is feedback. Once you've measured quality on particular measures, you can feedback the results to hospitals, physicians, and providers. You can have comparisons to targets or to other providers. But you're only comparing yourself to other hospitals and keeping it not in the public. So the hospitals will share the information among themselves, and the names could be blinded. So you could have Hospital A, Hospital B, Hospital C, and you know that you're Hospital C, but you don't know who's Hospital A and B. So it makes it a little easier for people to share because they're not, names aren't out there. But sometimes they share the names too. And some clinics I've seen where they'll start for the first year or two only with the blinded, so hospital or clinic A, clinic B, clinic C, and compare them. And then eventually, when people are more comfortable with the data, then they reveal the names. So you can see over time, and then by sharing the names, the nice thing about sharing the names is then you can share information about who's doing better and try and learn how the best people, so benchmark against the best people, learn about their accomplishments. So then you can also think about the range of quality measures to keep this more low cost in terms of the system itself, focusing maybe on stroke or hypertension or other high impact diseases, say for Indonesia. And then another topic is public reporting of quality measure results. So this is a newer trend to say once we have data from these quality measures, maybe we can put them out on the website. Because everybody's looking at websites now, right? Everybody likes websites. And you can have rankings of what? Restaurants? You can learn what's the best restaurant, right? And you can learn what's the best hotel. So why not the best hospital? And the best clinic. So, and this is of course harder to do because the hospitals and clinics would of course prefer the previous method, the confidential reporting, right? But now, and part of this is what is the health insurance organization doing? So is BPJS going to push public reporting of quality measure results? So if they are getting data on quality measures, and they are requiring the hospitals to provide data on quality in addition to the data for payment, then do they just keep that in feedback confidentially, or do they put it on a website? If you look at the US Medicare system website, they're now putting out the information publicly. They have a website called Hospital Compare, compares hospitals. Physician Compare, Dialysis Facility Compare. And so they're beginning to compare the hospitals and clinics and other providers on the websites. And interestingly, we interviewed clinics and dialysis facilities that were being compared, and we asked them what was their main interest in this. We thought they'd be concerned about patients looking and choosing the higher quality, but often that actually doesn't work so well, I think. That's one of the theories. My friends who are the economists, they like to have patients choosing things, they're like consumers. The patients really aren't quite like consumers. They're sick, they're scared, they're really nervous if you've got a bad disease. It's very hard to be a shopper at that time. But one thing we found is that there's competition. So not only do the patients look at the rankings, but the other doctors do, the other hospitals do. And doctors and hospitals, they're naturally kind of competitive people. You ever notice that? The doctors always like to say, I'm better than the other doctor. So, but the problem is if there's this ranking and you're down below, you want to do everything you can to get back up there, especially if it's in public. So, while the economists originally proposed this as a way of encouraging shopping by patients, actually I think the more powerful quality assurance impact of this is that the hospitals and doctors are naturally competitive people, and once things are out in public, they want to make sure that they are on the top, or at least not on the bottom. So that's a powerful, and especially these days with many people having internet access. Again, I realize there may be some parts of Indonesia where internet access is not easily available. Again, it can start in the big cities and perhaps move out. And finally, one of the new efforts in quality assurance is pay for performance. So this means linking payment to quality measures. So the idea is that the hospital gets paid based on a tariff. So if you have a particular case-based groups here, case-based group for, say, appendectomy surgery, the hospital will be paid based on a tariff for the appendectomy. But if the patient gets an infection at the hospital, should you pay the whole amount, or should you pay less? That's the way pay for performance works. So, because hospitals can do things to control infections and prevent infections. So, it's saying that we're not paying just for the service, we're paying for the service and the quality of the service. So changing the financial incentives. So right now, one of the dangers of case-based groups, and this was something that the person from Thailand was also talking about at the PE conference, is that when you move to case-based groups or DRGs, you have a cost-containment incentive to reduce the length of stay in the hospital. So that because the revenue is fixed, you don't want the patient there a long time because that produces higher costs. Right? But you still have an incentive to have more admissions. So maybe the hospital, because every time the patient comes in, you get another payment from the case-based group. So there's still an incentive to increase the volume of services. And so maybe the hospital will say to the patient, why don't you go home for 2 days and come back? Right? So we get 2 payments. So that's the incentive. I realize they probably wouldn't do that. But that's the incentive. So what we want to do is link the reimbursement to quality measurement. And another interesting benefit of this is reducing disincentives for staff time in quality improvement. So some of the hospital staff have said to us, we're trying to do quality improvement, but the management tells me to stop doing that because we don't get any reimbursement for it. So, because they want the doctors only to work on things where they get reimbursement from the health insurance or from patients. But if the doctor can say, well, we're doing quality improvement and that's now related to pay for performance, then the doctor can work on quality, and the management cannot be so concerned. Okay, so but there are some challenges in pay for performance. There are many experiments going on with this around the world. I know we were just learning about experiments in Korea. I've met with hospitals in Taiwan also working on this. The challenges is to how to implement this. So figuring out who to pay, how much to pay, what quality measures to include. How do you set targets for when does the extra payment happen or the lower payment happen? So these are the challenges that we've been working on this with the U.S. Medicare system now for a number of years. So it's a complex system to implement, but again, something to consider for the future. Right? And again, if you can focus, say, initially on certain areas like stroke care or hospitals, you may be able to link it with the health insurance program. Okay, so next topic is on measuring quality using health insurance claims data. So this is related to the new effort with developing the National Health Insurance System, your BPJS, and thinking about how the quality data could come in through the through the health insurance claims data. One of the benefits here is data quality. So we want good quality data on quality of care, because often the data are not of high quality when there's not payment associated with it. So the idea here, and this was again something that was stressed by the representative from Thailand at the FKP conference, that they have found that linking data collection to payment is a powerful way to make sure the data are of high quality, because the BPJS can say, if you don't give us this data correctly, we're not going to pay you. And that gets people's attention, right? Because everybody wants to get paid, right? So if you're just saying, oh, send us information on all your diagnoses and we'll put it in a book or something, people are too busy for that, right? But if you're telling them they have to do it to get paid, then you can enforce the data collection. And so that means that when you have high data quality, you can use it for other purposes, such as quality measurement. And the key will be to work with the health insurance organization to ensure that the claims data can also be used for quality measurement. And as I was saying, you can think about that as an option for BPJS in the future. Okay, so here's some examples of quality measures. I'll run through these, and I'm happy to share these PowerPoint slides with anyone. I guess you have a copy here, so you can follow up also. I know time is running a bit short, so I'll go through these fairly quickly. I think they should be reasonably clear, but I'm happy to discuss further. So one of the ones for hospitals that we talk about a lot now is readmissions. So when the patient is discharged from the hospital, can they stay at home or do they have to come back? And if they come back to the hospital within 30 days, that usually means the hospital did not do a good job, right? I mean, not always. Some people are very sick. But we can compare the rates of readmissions across different hospitals and say who's doing a better job of taking care of their patients because the patients are not going back to the hospital. And the great thing about national health insurance with BPJS or Medicare is we can track, even if the patient goes to a different hospital, right? Because the insurance data will have admissions to all the hospitals because they'll be paying all the hospitals. So we don't have to be concerned that the patients are going to other hospitals. And readmissions are also very important with the incentives under case-based groups. Again, as I was saying earlier, there's an incentive under case-based groups to increase the number of admissions, right? So if the patient goes home for 10 days and comes back, then the hospital gets more money. So is it a good thing or a bad thing that the patient comes back after 10 days? Is it good? That's bad for the patient, but good for the hospital. This is the problem. We don't want to have mixed incentives like that, right? So we need to measure readmissions and make sure we're tracking those so the hospital's financial incentives don't get in the way. And we can also look at preventable hospital admissions, which are things that should be cared for on an outpatient basis and can also be compared across different hospitals. Same with emergency department visits. We don't want people going to the emergency department for things that are not severe. But again, if a patient comes to the emergency department and the hospital can then bill the health insurance, BPJS, is that a good thing or a bad thing? Yeah, again, it's bad for the patient, but good for the hospital. So the hospital may like having too many people coming to the emergency department for financial reasons under health insurance. And patient safety. So as I mentioned before, hospital-acquired infections. For those of you who may be in the medical field, venous thromboembolism, this is like pulmonary embolism when the blood clot forms in the patient. This is a big problem in many hospitals around the world. So how can we help prevent those blood clots that can often cause death of patients in the hospital? Also, pressure ulcers. If a patient lies in a bed too long, they can get an ulcer. And the hospital can do some very simple things, just turning the patient regularly to prevent the ulcers that can then get infected and cost a fortune because you have to use very expensive antibiotics to treat these. And it's a big problem for BPJS, again, in cost. So if we can prevent decubitus ulcers, we can really hold down the cost. And it's a win-win because it's the patient doesn't have this horrible ulcer, which is so painful, and BPJS does not have to pay money. So the patient feels better and BPJS feels better. And then allergic reactions to drugs. And then stroke, again, because this is an issue I know here in Indonesia, is the patient being discharged with the right drugs? And does the patient know how to use the drugs? Are we having anticoagulation drugs like warfarin prescribed for patients with atrial fibrillation? You know that can help prevent blood clots. So these are some examples of information that can be included in the claims data if you have information on the diagnosis and the drugs being given to the patient and what the DRG is. And then we can compare different hospitals. Who's doing better at treating stroke with these basic measures of getting the right drugs to the patients. And then diabetes, as I mentioned, we have the testing. We also have the control measures, like we can do the test, but also the results of the test. If we know the test was done, we still don't know if the patient was being treated well. And 9% is the standard that's often used. Some of you involved in healthcare, 9% with usual approaches here in Indonesia. Some people told me 7% here in Indonesia. So you can have discussions over what's the right level. And you can measure whether the level is helping to evaluate whether the patient is being treated well. Coronary artery disease, again, they're getting the right drugs and the tests. Hypertension, what's the right frequency for testing blood pressure? And what's the level at which we know if blood pressure is under control or not under control? Plenty of preventive care, we have many vaccines, cancer screening tests, say mammograms every 2 years for women of certain ages, colorectal cancer screening and immunizations. These are all examples of measures that can be collected using health insurance claims data from BPJS. Also, regional indicators. So if you have hospital readmissions, we can compare them across provinces, kabupaten, kota, see which areas are doing better on this and which are having more problems. And then have the ones that are having problems go visit the ones that are doing well and find out what they're doing better. Next is health insurance claims data. This is to give just some examples of what is required. This is getting down to the detail level, I realize. But just to give you an idea, once we know that measures can be collected in insurance claims data, what are the exact data we need? And I don't want to keep this at too theoretical a level. I want to say, what do we find is really needed? So I'll give some examples here. So beneficiary data, we need to know the gender, date of birth for age, because many of these things are age-related. National ID number. There's some discussion about how to collect a national ID number for BPJS. where they live, if we're doing the regional comparisons, date of death if they've died. We need registries of doctors and hospitals, so again we can know what the still have 5 minutes. We can know which hospital the patient was treated at. Again, if we want to compare hospitals, we need to know which hospital the patient was treated at. And also, we want to compare doctors or clinics. What is the basic information we need? So what is the basic information that BPJS has to require the hospital send to them when they send their claim for payment? And then BPJS can make sure they get all this basic information. And then a lot of this is also used for payment as well. So inpatient data. So here we need to make sure we have date of admission, date of discharge. We know the diagnosis code, so we know if the patient had a stroke. We know how many days they were in the hospital. We can also check for readmissions if we know date of discharge. And was the next admission within 30 days or not? So we need to make sure that BPJS requires this data from the hospital when they submit the claim for payment, so we can have the information needed for the quality measures. And then the pharmaceuticals, the drug codes for the drugs such as warfarin for preventing blood clots. Outpatient claims data, again, we need diagnosis codes, say for the diabetics, people with hypertension, so we know that they're getting the right treatments. Similar for health centers or clinics, make sure they're getting the right tests for the people with particular diagnoses, physician claims data. Laboratory claims data, again, we're looking, as I mentioned earlier, about the results of the test, with the diabetics being well controlled under 9%, or cholesterol level. I can tell you my cholesterol level is above 130. My doctor has me on a drug. So as soon as it went up there, he said, "Oh, you've got to get on that statin drug." I complained, but he said, "That's the numbers." Yeah. So I know he was being good to me. And pharmacy claims data, so we know what drugs patients are getting. Okay, finally, some conclusions. So I think the general message I want to recommend is that to recognize that quality measurement and quality assurance can have large benefits, as we've been discussing, in terms of linking access to care that you're getting through your universal health coverage to improving patient care and outcomes for quality. But quality measurement and quality assurance can have large costs. Sometimes it's new systems, sometimes requiring new organizational cultures or behaviors of doctors. So this is something that has to be balanced. So the benefit of quality measurement through health insurance claims data, say through BPJS, is it can reduce the cost of quality measurement because you're linking it with payment and requiring it of the hospital and maintaining data quality. So each country's Ministry of Health and health insurance programs, I think, needs to reach their own balance. We've seen, we work on this a lot, on what's the right balance for the United States. There are people working on it in Thailand, in Malaysia, and Indonesia will need to develop its own balance. But consider what are the benefits of what types of quality measurement are important and what types may be too costly at this point. So several strategies to improve the ratio of benefits to costs I'll leave you with as possible approaches for Indonesia. So focusing on, at the bottom here, on selected diseases, as I've been saying, stroke and hypertension I know are important diseases here for Indonesia, so maybe focusing on those first. Other ideas, focusing on provinces or cities that have better developed systems, so maybe focusing on hospitals in cities in Java. Some of the eastern provinces like Maluku, they have less resources available, or Papua. Focus first on hospitals, perhaps, because they have more resources for data collections and trained staff. And keep a focus on services covered by BPJS so that the health insurance claims data can be a source of information. Then phase in groups of different quality measures over time. This is a an approach that's I think used in almost all countries with this types of approaches. Thinking, starting small and building up over time, because there's a need to test the data collection methods, test the feedback methods. What's the most effective? Do you want to focus on confidential feedback of the results to hospitals and doctors? Or put everything out on the web and let everybody first compare the restaurants, right? Find the restaurants that are close to the hospital, and then decide what's the best hospital. So that's the end. I'd be happy to discuss further.
Thank you, Michael, for putting my thumb. Okay, I think I will let the audience we can have more discussion further on this issue before maybe at the end I can sum up of this the discussion and also the presentation. Okay, we can have three people to have questions first. Bapak and Ibu Melopar. Please say your name and your institution. Thank you.
Thank you. This is a really interesting presentation. My name is Herman Harun from Kajian Social Protection Program. I'm a medical doctor by training, but no longer doing my practice. According to this new social health protection program in Indonesia that will be started by 1st January next year, we face two main problems. First is the supply side readiness. A lot of issues related to this, and the next one is the payment mechanism that will have a close relation with the quality of services. According to the supply side readiness, let's look at the human resource for health, like a medical doctor, and look at the current Jamkesmas activity. Yeah. As you mentioned, the clinical guidelines or clinical standard for primary care. Between MOH and the professional association, they set up before, they mentioned 179 diagnoses should be well treated at primary care level. But in the reality, the primary care just referred it to the hospital. And the impact on health financing is a big claim spending. So now they reduced the number of diagnoses to 144. And then when I asked how to assess the quality, the competency of medical doctors, there is no tool right now at the MOH. And when I asked the PJS or PTASKES, can you link this to the credentialing criteria? And then they just surprised, and then they said, yes, it has to be there. So how to deal with this? And then next step is how to assess the gaps within the minimum requirement of competency and the existing competencies, and how to fulfill this. Who will pay for the let's say training, or this is not the classroom training because this is a vocational for the skill. So should government has to pay or BPJS has to pay, because this is, I quote to them, this is investment for cost containment. Yeah. Or the medical doctor themselves to be certified later on, unless they will not get contract from the BPJS. So it means in the long run they will lose the captive market. So this a big issue for starting up on 1st January. Or should we set up the strategic plan to ensure the quality after 5 years implementation. There is still no real strategy plan to do this. On the other hand, for the next issues is the payment mechanism, capitation for primary care, and reimbursement for the hospital. If we learn from the, we have done several assessments for only for policy of Askeskin. They only have the safeguarding for claim for payment, but there is no safeguarding guideline for the real medical services and quality services. For instance, several abuses of this Jankers must before or Askeskin before administratively discharged and readmitted to the same hospital without physically discharging and readmission. So they have been discharged administratively this day in the morning, and the afternoon they readmit again without real discharge from the hospital. So this needs some measurement, like audit or whatever. Yeah. So a lot of abuse. And then related to those, what about the supply induced demand? How to reduce the impact of supply induced demand that this is beyond of the economic condition. Yeah, this is specific on health or medical services. Probably this is not too much for the discussion. Thank you.
Thank you, Dr. Michael, for the presentation. My name is Andy. I'm working at the governance for public relations. I just want to ask, follow up from the previous question about the supply side. As we know that for the implementation of the universal health coverage, I think the government only provide the services for kind of like low class room in the hospital, especially for the poor. And I'm just wondering if the hospitals in the first place have like kind of like low expectation of services that they will provide for the poor patients. They will not be having any incentives to increase the quality, as that you have been mentioned, that these hospitals need to provide good quality services even for the poor. So what kind of like strategic like steps that the government can have to make sure that these hospitals provide good quality for the poor? Thank you.
Ibu Kilburn, actually mine is also similar to Andy, that I think in the nature, the spirit of all of this, there was related really to poverty reduction, to core component of this and greater social justice. And thank you for a very interesting presentation. I'm by no means knowledgeable very much in this area, and I have to learn quite a bit today, but I couldn't really see the spirit very much of social justice, making it pro-poor, how it is different if you want a program that really targets the poor, because the rich, many of them will be going to Singapore in any case. So this is really a program that has the spirit of increasing social justice in the region. I didn't see that coming out a lot in your experiences, and I know in America it's also a very big challenge, and it's by no means resolved at all either, so maybe that's why it doesn't come out so strongly in your presentation, but nevertheless I would appreciate the experiences you do have in making all of this more attuned towards greater social justice.
Thank you. I think I can, my colleague can respond to all the questions at once.
Okay, I'll try and cover them all. I think the way I view this in terms of pro-poor policies, or poverty reduction policies, is that it's very important that poor people get high quality care. And one of the challenges in the U.S. is that often people who are poor do not get high quality care. And for example, they suffer from many of the complications of diabetes much more than wealthy people, and complications of hypertension and other diseases. And so being treated in a clinic where people, sometimes the poor have to go to clinics where doctors are very busy. And they're crowded, and the doctors see the patient for 2 minutes. And how good a quality can you give to a person in 2 minutes? I mean, whenever I see my doctor, I think they give me 15 minutes. And I often have to stand between the doctor and the door to the exam room and make sure the doctor doesn't sneak out really quickly. I wanted to keep talking to the doctor. And so I think one of the challenges is that we can provide basic access to the poor, say to doctor visits, nursing visits, but what does that really mean underneath it all? I mean, does it mean a 2-minute visit where the doctor just makes a prescription for antibiotics just to try and move the patient along? And so I think quality of care is a very important pro-poor policy because also the poor tend to suffer disproportionately to non-communicable diseases, for example, from diet, exercise issues, as well as infectious diseases, say from water and sanitation issues. And so by improving access to care, I think is very important through Jamkas Mas for the Poor and now BPJS, but also making sure that those services really benefit the patient care, because in the long run, that's going to benefit the health outcomes for the entire country, and it's going to help make more money available in the long run by preventing these complications, say, of diabetes and hypertension, make more money available to provide more services to poor people, and also help people stay more healthy so they can become productive and have more opportunities for work and helping themselves and their families get out of poverty.
Can I just interject one other point about what's our experience in actually doing this? I think you can speak more to this, or we can speak later, but there is an entire group within our chat that looks at social justice on underserved populations, not just the poor, but including the poor. There's a large public insurance program called Medicaid that serves the poor, and Mike's group and other groups, I think, have done a lot of work on working with that organization to institute quality measures in the insurance claim system, again, specifically so they can see, do Medicaid patients receive adequate quality of care? And the other thing I wanted to say is that I think one of the benefits of the universal health insurance program is that, yes, you'll have the varied rates that will go off to Singapore, but anybody who doesn't have the ability to go off to Singapore, the hospital gets the same reimbursement from the poor person or the not poor person. The difference is really in who pays the premium, not what the hospital gets. So the hospital should be somewhat blinded. And these quality measures that Mike's been talking about, and I think that where RTI is about to launch a large body of work in the U.S. under the healthcare reform that is going to give access to poor people, uninsured poor people. And I suspect that some of the work that we're doing is going to be to look at the quality of care of people in those new and previously uninsured groups. Is that accurate, Mike?
Yes. A lot of our research also focuses on what we call disparities, which would probably be similar to, as you say, poverty reduction here. So disparities of treatment of people of different income levels, ethnic groups, gender issues also in healthcare. How can we make sure that the same access and the same quality of care both are provided to people of all economic levels, including poor, all ethnic groups, all, make sure that there's gender equality in healthcare as well. So what I think our perspective is that, again, what I'm trying to emphasize today is we certainly are very positive about the expansion of access to care as an important anti-poverty movement. And Indonesia universal coverage is a key goal around the world, and we're still struggling for in many countries. So access is very important for poverty reduction, but also quality is important, and sometimes quality is not given as much emphasis as access. So if you have access, but it's low quality care, are you really benefiting the poor or not? And we don't want to spend the money on things, the limited money, on things that are not of good quality, and they're not going to really help the outcomes, because that will help prevent future diseases and complications, and also make sure that the quality of care is good so the patient can get better and have opportunities for employment and to help take better care of their families.
But is it the right step, as Pak Andi said, that what are the strategic steps to provide the good quality of healthcare? I mean, we have an access strategy now, but what the next step?
Sure, I would say that the key step would be to identify what are the most important diseases for the poor. Is it hypertension? Is it infectious disease, say by sanitation issues? And then focus the quality measurement on those specific services. It's hard to measure quality in everything. It's very expensive to do that. But you can identify what are your key diseases for the poor, and then begin emphasizing the quality measurement there, so that the access that's provided by BPJS will improve the quality of care for the poor people.
It's quite straightforward. And maybe your comments on Pak Hangman's statement about the two main problems we have in the previous, and then also for the implementation of the BPJS and universal health coverage for the sickness and readiness, and then how to reduce supply-induced demand. Maybe your comment?
Sure. Yeah, supply-induced demand, I think, is a challenge whenever you have a health insurance system that has fee-for-service reimbursement, as we say. So there's always an incentive in fee-for-service reimbursement to increase the volume of care. And because the doctors have a lot of control over the diagnosis of the patient and recommending treatments, there's the risk of supply-induced demand. Now, again, the case-based groups are one way to start working on that, because you're reducing one incentive, which is once the patient's in the hospital, the case-based group, then the incentive is to limit the amount of care, because you're getting, the reimbursement is fixed, revenue is fixed, so then you don't want the patient to stay longer, you don't want to do a lot of expensive tests, financially. I mean, I'm speaking just strictly financially now. So that's positive in that sense, but it still does not remove the incentive to increase the number of admissions. And I would say the challenge there is to think about utilization review guidelines. In the long run, there is the option of moving to capitation for everyone, for all services, not just for primary care. But the risk, as you may know, is that then there's the incentive for under-treatment. Even with DRGs, there's a lot of criticism, with DRGs, case-based groups, there's a lot of criticism of, they say that the patients are discharged by the hospital management, they say, quicker and sicker. Because they want to get the patients out, because they've already got their revenue, so why don't you go home? And that's the financial incentive, is to discharge the patient quicker and sicker. So the balance in healthcare is between the incentives for increased volume of care versus the incentives for under-treatment. And that's where quality measurement can come in, because as you reverse the incentives, and we say now the incentives are for under-treatment, then quality measurement is a way of checking on that. Because, again, you say for quicker and sicker discharges, then you can measure that by looking at readmission rates. So if the patient is discharged quicker and sicker, are they coming back to the hospital because they weren't really cured within 30 days or whatever your guideline is? So by reversing the financial incentives, you reduce costs, you reduce supply-reduced demand, but you increase the risk of under-treatment. That's, I think, just inherent in those financial incentives, so that the mix, as we think of mixing payment and quality, that we can have the mix of payment incentives to reduce costs, but then also having a quality measurement to make sure that under treatment is not the way of reducing costs. And that's because the way to reduce costs with financial incentives is two ways. One is better care so the patient gets well and does not come back, or does not have complications of diabetes. Another way is to undertreat them and discharge them quicker and sicker, and then say goodbye, and we'll take our revenue and move on. So the balance is trying to emphasize the first goal of cost containment by improved quality of care, improved healthy population, improving the health of the population, and avoid the incentives for cost containment through just simply undertreating the patients. And the poor are often those that are undertreated. So this is again an anti-poverty, pro-poor policy to look at quality and make sure that the poor are not the ones suffering under treatment and not being pushed out of the hospital too fast, the quicker and sicker. Perhaps because they're lower social status and they'll just be more easily discharged than someone who's wealthier and has more family connections or whatever.
I think we can still have two or three questions. Anybody? Yes. Yeah. Bapak.
Thank you very much. I just have a question about
Sorry,
the
your
connection
name?
between,
Your
I'm
name?
sorry, yes, Jeffrey Sane from RTI International also. I'm actually based here in Yogyakarta. I've met some of you before, and pleasure to be back. Mike, I was very interested in some of your suggestions about quality of care measures at hospitals, for example, measuring complications from diabetes as an indication of poor quality of care. But my question is, well, how do you make the connection between primary care and hospital care? So the hospital may get a diabetic patient who needs an amputation because primary care has been poor and may not have been their responsibility and their fault. So how do you make sure that you're not penalizing the hospital for care that should have been provided in a different setting, but wasn't?
Yes, it's a very good point, and it's important to focus the quality measures at the different levels on the types of care that are, say, under the control of that organization. So, for example, in hospitals, we control things like hospital-acquired infections. Was there the right drugs given to the patient given the disease that they have? Then the broader issues of, for example, diabetic care, is the patient getting the diabetes testing once per year? That may be a responsibility for that community. And it may be that we then move to the regional indicators to say, how is diabetic care happening in this kabupaten or this kota? And how do we develop a plan for improving the quality throughout the kabupaten that may include puskesmas, may include the hospitals, may include private doctors as well. And by having the ability to look at the measurement of the other, again, the nice thing about national health insurance is that you have information on services provided in many different places, so you can have an idea of was the patient receiving this service, even if it may be across hospitals and clinics. But it is exactly important to make sure that the responsibility for the quality measure results is presented at the right level. For example, the city of Indianapolis in Indiana now has a website that publishes the quality measure results for the city. And they say, here is how our city is doing, and we are going to make a commitment as a city to try and improve them. And we know that there are many providers in the city. And sometimes they will also publish results for specific hospitals or clinics when their responsibility can be identified. But they're also making so the responsibility can be at different levels. But they're saying, and they publish this on the website and they're tracking it very publicly. So I give the politicians in the city a lot of credit for taking a risk, because they're putting this out there. And then if they don't succeed in improving the quality measures, everyone's going to know it. So we have the leadership of the politicians taking responsibility for the public's health and measuring it very, very openly and saying, we're going to try and make this improvement. And so that's another approach that could be used.
So the quality measurement can be also, or should be also related to the public accountability, right?
Yes, yes, yeah.
Ibu Mia? Thanks.
Yes, thank you. To what extent do you think quality assurance handled by other parties, not BPJS or the government, like the encouragement of government to that hospital and healthcare get their ISO certificate can help solve this problem. At the moment, there are in many districts, there are quite many health service has this certificate. So probably BPJS can be more comfortable working with this kind of hospital or health service with this ISO service.
Yes, I think that's certainly an important step. I would categorize that under the licensing and accreditation input measures. So you can have a basic measure of the quality of the organization. There are international bodies that do accreditation or certification, and that is an important first step. I certainly agree. But at the same time, once you have that certification, you can have some more confidence. But you still don't know for certain how things are happening with particular diseases. And so that's the kind of the first step of the input measures of quality. I'll see if I can go back really quickly. Too many slides. There it is. So we talk about the input process and outcome measures. So we can say, for example, for a region, if the city of Jakarta or Jogja want to make a goal for quality of care in their city, they can start with a mix of these measures. So we can say which of the hospitals and clinics have ISO or other certification, what percentage of them have it in our community. And that can be on the website also. And then we can also say how are diabetics being treated in this city. So it's a kind of a combination of both. So we want to say we do have ISO certification for our clinics and hospitals or other accreditation. But we also want to focus in maybe on other quality measurement of high impact diseases for Indonesia, such as stroke, hypertension, diabetes. So I think it certainly is important to do both.
From SMERU. Thank you for very informative presentation. I really learned a lot today. I would like to discuss with you on the issue of trying to improve quality assurance by making public the results of the quality measurement report. Of course, the hope is that hospital or clinics will respond by improving the quality, so they will become classified as good quality hospital or clinic. But in a corrupt environment like in Indonesia, the response might be different. Yeah. We can learn from other sectors. For example, I have a friend who works in an organization whose job is to measure the performance of districts. And every year they announce the best performing district and the worst performing district. So once in a while, they will receive a visit or a call from head of district, bluntly asking, how much I should pay you, so this year my district will be the best performing district. So I guess we will have to think also about who should be quality measurement and quality assurance, and how to make sure the integrity of the whole system.
Yeah, that's a very good point. It's certainly a point that comes up in the U.S. as well, in other countries. I would say one of the, again, I go back to say the health insurance claims data, because again, one of the benefits of that system is that because BPJS will be using it for payment to hospitals, then there's more of a focus on making sure that the data are correct. So that, for example, in the U.S., there would be a random sample. We would say 5% of the claims would be checked by an audit. I don't know what the procedure might be here in Indonesia, but because there's so much emphasis being placed on the data being accurate for the case-based groups, that the method for checking the data to make sure the payment is accurate, then at the same time is automatically checking the data for the quality information too. So again, I realize that the system will never be perfect because checking all the data would be too expensive. But in the ways that EPJS will be working to make sure the data are correct, and checking the data accuracy when it's submitted to them by the hospital for the case-based group payment, then that can also help make sure that the quality data that are also in the claims information is also correct. I realize that there's always the opportunity for corruption to creep in, and that will probably be an ongoing issue to work on. But one of the strategies can be by working with BPJS and using its methods for checking data to help work on that issue.
I think the time I remember someone raised her hand. Maybe a bonus for one quick question.
One quick comment.
Okay.
Thank you so much, Michael, for the presentation. It's my pleasure. We met last week at SMERU. I'm Tatiana Makarov, freelance consultant from USA. I just want to add a little bit to the previous answers because what Michael has shown today can give some examples and some additional answers to his points. For example, to the answer about relationship between quality measurement in hospitals and primary care or specialist care or patient specialist care. I think those slides, for example, that Michael demonstrated today about measurements of inappropriate hospital admissions or inappropriate emergency visits, it's actually a very good cluster of indicators that can be measured. Being measured at hospital levels would inform the system that there are flaws of the lower levels of delivery. Service delivery, and let it be any form of primary health care delivery settings or specialist outpatient care. So that's, and actually it has been tried in several countries, although this is much more complex system that requires different information integration. So another comment that I would like to make is that overall, all these concerns expressed about equity considerations basically call for majority of indicators that you will be selecting to be stratified by cohorts of population in question. It looks like that Indonesia will be very much interested to see not just an average indicator for this or that quality measure, but to say how it looks for an average citizen or an average consumer, but how it is also looks for those particularly in question, let it be impoverished, let it be poor, let it be other disadvantaged groups. I would see much more sophisticated, I will say, algorithm of measuring and researching quality, because our population is not, I would say, harmonized in a way, and our concerns of access and quality are different regarding different population groups. A little bit, just to stress a little bit about linking financing and quality. It was very well explained today that it is clearly a way to go, and many countries exercise financed results, performance results, financing, or performance for results payment systems. I just want to tell you that when we try those systems in many countries, what we try to look for will be any indicator reactive in terms of changing provider behavior. And providers, very wisely, please consider them at two levels. One provider level is organization per se, starting with the management, starting with the chief doctor. How this particular entity as institution will be reacting or not reacting to particular measures and incentives that will be built into performance, into financing incentives. Another question is, will be these incentives of performance measure channeled towards remuneration, towards payroll of employees or not? I mean, in many systems where these performance incentives, they stock at the management level, and you look into salary history, there's no change. What would you expect if your real performance are doctors and nurses and other medical and non-medical staff members? So that's very important for consideration. And actually, in quality measures, you can also build profiles that inform you not only about averages in the institution, but profiling different kind of workers and different kind of staff to compare. And another thing is also, it is truly researched and advised that you will likely receive delivered those indicators that you measure, that you care about, that you report. It may take time, but you may see some improvement, and you may see really care about those measures that are in consideration, that are under some kind of monitor. The question is, will you be concerned that maybe other sides of quality will be then neglected in a way? Because when you really focus on some particular cohort, some selection, you may be at risk. What we try to do in one country, I wouldn't name the country, what we try to do, we developed a list of selected indicators. There were 28. But what we decided to try in primary care settings, we will not inform doctors which 7 indicators every quarter we would select for performance, for financing rewards. You see what we did? It was a little bit blinded system. They weren't to work well across 28, although you would agree 28 is also selection. It's not 228. And again, it's another meta. Be very considerate and wise how many indicators you want to actually track, because usually you want to do too much, or sometimes you have to really refresh the system, because you may care about those aspects of performance that are lacking, that are of some concern. And then once you see some upgrades, as Mike will show us, this average upgrades, then you may say, okay, maybe we will drop the indicator for a while for monitoring, because we have other aspects, to be more concerned about, to be measured more precisely, or to boost towards improvement. Anyway, but that's a very interesting, just to think psychologically and to test, of course. And one last advice, practical advice, is monitor and evaluate your quality measures in terms of receiving response and behaviors of institutions and providers as employees or not. Just be wise measuring how your measurement and reward system, if it will be any, let it be financial, non-financial, is working. It's very, very important to build this mechanism, because there is no one answer, there is no one customized methodology. You will be always on a track of looking for something wiser, sharper, more concrete, wider or narrow in your choices for quality measurements. And of course, your areas of quality improvement will be evolving over time. So it is just some practical advice to add to, because it was all in Michael's presentation. I just wanted to highlight some aspects that may add also to answers. Okay.
Thank you.
Thank you.
Michael, do you want a response or?
No, I just say that I think many of those comments I certainly agree with. That there are many issues to work on as you consider ways to measure and ensure quality, and I hope that what we've discussed today will assist in your long-term development of BPJS and the anti-poverty and pro-poor policies that will benefit your continued work on healthcare.
That's a very important message. Okay, I think we have to come to the end of the seminar. To sum up, we have very, excellent presentation from Michael on how to link access to healthcare with the quality of healthcare itself. So I think this is provide background for us for further maybe public debate after we finish arguing about the other crucial issues related to the cost, how much the premium for the BPJS, and then now maybe we move forward to other side of the healthcare, the universal healthcare implementation towards the how to establish the good quality healthcare in Indonesia. Thank you, Michael, for the enlightenment. I believe you are not only public health scientist but also economist, because you did your undergrad and master also in India, right?
Yes, well, actually my PhD is in healthcare policy, so we do try and take what we call a multidisciplinary approach. So we look at clinical care issues, we look at economics, we look at psychology and political science and sociology. So try and bring all those different perspectives. Because I think healthcare is a complex field and needs perspectives from many different disciplines to get better.
So let us give a big applause for Michael. Actually, thank you for sitting here for 2 hours with us. And then, we have a very interesting souvenir for Michael today. Maybe pass it to you. For all of us, we provide lunch box for all of us. You can bring it home or you can enjoy it here. Thank you. And for your information, we still have 5 seminars on next Wednesday we have topic on food price volatility. See you next week. Thank you.